It's an honor to be here amongst you all today to give this lecture on IAMICON conclave. This is the second time I'm in this meeting here. I thank Candela Pharmaceuticals and his team to invite me to this evening's lecture. I thank the IMA, Dr. Agraman, Dr. Tirupati Garu, Dr. Mohan Rao, and Dr. Kailas Papa to be here this evening to listen to this topic. When they told me that the topic is chest pain beyond MI, I was a little surprised. I said, why this topic? People are talking lots about acute coronary syndrome, myocardial infarction, interventions. But they said, we want to have something different. And said, chest pain beyond MI. Nice. What is the goal here is that we need to differentiate potentially life-threatening cardiac and pulmonary problems that are usually the focus of the initial diagnostic workup for chest pain, and exclude some of the simple, irritable causes like musculoskeletal pain or gastroesophageal reflux disease. It is one of the most common causes which people present to the emergency department and to the chest physician or to the general physician. And the etiologies of chest pain range from life-threatening conditions that are relatively benign. The most common causes are from the musculoskeletal system and the gastrointestinal conditions. When they did some studies, they found that about 30 to 50% of the times, the pain is from a musculoskeletal origin. And about 20% of the times, it's from gastrointestinal causes. Another 10% is from chronic stable angina. And about 5% is coming from acute coronary syndrome. So just 5% of patients who will end up in the emergency department or with the physician have an acute coronary syndrome or myocardial infarction. Majority of the times it's a gastrointestinal or a musculoskeletal disorder producing the chest pain. So we're going to address this topic of chest pain beyond MI with under the following headings. We are going to look at a wide range of etiologies: cardiac, vascular, pulmonary, gastrointestinal, musculoskeletal, infection, psychological, that is a panic attack. Can't miss causes of chest pain because they are going to be lethal. They're going to be hemodynamically unstable patients, which can lead to death and mortality or morbidity. How are we going to approach these patients with chest pain, and how does one distinguish the different causes of chest pain? I'm going to give some case challenges about how I faced a few cases and what are the difficulties I had. One needs to understand that one should avoid focusing only on acute coronary syndrome, as there are lots and lots of other causes for chest pain than acute coronary syndrome. We just said it's 5%, and only about 10% of the patients who attend the emergency department have a coronary etiology for chest pain. There are lots of non-coronary cardiac causes for chest pain too. Non-coronary cardiac causes. So you are looking at coronary cardiac causes and non-coronary cardiac causes. So if you ask your patient, who is your papa, this is just a mnemonic to tell you that the first two of PA, papa, have to do with the heart, pericarditis and acute coronary syndrome. The next two P's, pneumothorax, pulmonary embolism, and the last A is going to stand for aneurysm. So it's just a small mnemonic to remember that these are the causes which one should not miss because it could be hazardous to the patients. So the 6 can't miss causes of chest pain are acute coronary syndrome. We're not going to talk about this. Pulmonary embolism, a very important cause if delayed in diagnosis, if delayed in treatment, can lead to death. Aortic dissection, esophageal spasm, rupture, tear, so many causes. Pneumothorax, pericarditis. So these are the various 6 causes which one should not miss, and we're going to address each one of them briefly. So we all are aware of the pain for a patient with angina. I would like to review these 2 slides and tell you a typical angina. A typical angina has to have 3 features. A substernal or retrosternal pain with the characteristic quality of burning, bursting, pressure, heaviness, tightness in the chest. So this is very, very important. The location of the pain is very important. Aggravated by exertion, relieved by rest. And the duration of the pain. So the location of the pain, the quality of the pain, the aggravating and relieving factors are very important to say this is a typical angina. If you don't have one of these 3 features, it becomes atypical angina. So if you have only 2 of the above criteria, it becomes atypical angina. And if you have only one of the criteria, that the location is retrosternal, but the quality is different, there are no aggravating or relieving factors, it is non-cardiac chest pain. This is the clinical classification of chest pain. So how do we diagnose angina? We diagnose angina by clinical methods, clinical history, and clinical history. Angina is a clinical symptom of chest pain because of myocardial ischemia. It's a clinical symptom of it. There are no investigations. There are some atypical descriptions for chest pain. The pleuritic pain, knife-like pain brought on by inspiration or cough. And the primary or sole location of the discomfort in the middle or lower abdomen. This is unlikely to be of cardiac origin. Pain that may be localized at the tip of one finger, particularly in the LV apical region. If somebody is going to point out the apex of the LV and say this is the place where they have the pain, it's very unlikely to be of cardiac origin. More of pleuritic origin or pneumonia. If there is a local tenderness, if there is a constant pain that persists for many hours, very unlikely to be a coronary injury. And a very brief episode of pain lasting a few seconds. So I just had a pain, brief pain, lasting 2 seconds, 5 seconds, very unlikely to have coronary etiology. And a pain that radiates above the ears, below the umbilicus, or to the lower limbs is a very atypical description for chest pain. And you need to think of non-cardiac causes of chest pain. There are a lot of atypical presentations for acute coronary syndrome and angina equivalents like jaw pain, shoulder pain, unexplained dyspnea, new onset class 3 dyspnea, nausea, vomiting, multiple belchings, first time indigestion, acidity, profuse sweatings, mania. There are the various atypical presentations for an acute coronary syndrome. Nevertheless, these presentations can come along with some atypical symptoms like local tenderness. So just because there is a local tenderness, one does not rule out a coexisting coronary artery disease. Women, older persons and diabetics are more likely to report atypical symptoms. So if you look at the pre-test likelihood of CAD, these lines. If you look at the pre-test likelihood of CAD in symptomatic patients, according to age and sex, somebody is having a non-anginal chest pain, that's only one feature of the 3 classical features. The probability of having a CAD for a 40 to 49 is 13%. It's not zero. It's not zero. For a patient with 2 features is 50%, and a person with 3 features is almost 80 to 90%. So depending on the history of the 3 atypical features, one can decide is it coronary artery disease or not. And comparing the pre-test probability for low risk versus a high risk patients. Low risk is patients who don't have risk factors like diabetes, hypertension, dyslipidemia, smoking. And a high risk involves patients who have risk factors like diabetes, hypertension, dyslipidemia, smoking, obesity, family history, and so on and so forth. So if you are a 45-year-old male, no risk factors, the risk of having heart disease is 9% for an atypical chest pain. It becomes 47% if you have the risk factors. So you decide the typicality or atypicality of the features of the chest pain along with the risk factors, and that adds to the risk categorization of the patients. Let us say a 45-year-old male who has risk factors, the chances of having a chest pain, coronary artery disease is about 70%. And the same individual, 45-year-old, has risk factors. For a male, the risk is with the typical angina is 90%. So depending on the risk factors, one decides whether you have a typical angina or atypical angina, and the risk factors make the situations more clinically targeted towards a coronary workup or a non-cardiac workup for the investigation. So approaching a patient with chest pain, all of us know that we do the first investigation of choice. We take the history, we look at the ECG. Sometimes, if the pain is very atypical, sometimes we can do a stress test within 24 hours. And in some situations, we directly go for an angiography. Sometimes we do a chest X-ray to rule out a pneumothorax or an aortic dissection. And if the initial workup is negative, ECG is normal, X-ray is normal, echo is inconclusive or normal, and the biomarkers, troponin, CKMP, CPK are negative for acute coronary syndrome, one goes to this flow chart. So you assess the risk for acute coronary syndrome and look at the biomarkers. If they are elevated, you have a diagnosis of N-STEMI. If your history is consistent with acute coronary syndrome, but the biomarkers are normal, angina, possible coronary artery disease. But if your history is not consistent with acute coronary syndrome, it's not having three atypical features, and the biomarkers are elevated, it could still be a non-STEMI. The presentation is atypical, but think of an alternative cause for cardiac injury in the form of myocarditis, in the form of some injury. But if the history is not consistent with acute coronary syndrome and the biomarkers are normal, think of an alternative diagnosis. If your acute coronary syndrome is not etiologen, one has to look for pulmonary embolism, the next important thing which could lead to a disaster. If the clinical risk is low, clinical probability is low, and the patient is coming to the outpatient department for the first time, one can do a D-dimer test, a third generation ELISA D-dimer test. Practically rules out pulmonary embolism, 90-95% sensitivity and specificity. But if your clinical suspicion is still high, one could still go ahead and do an imaging in the form of a CT pulmonary angiogram or a ventilation perfusion scan, and then rule out the pulmonary embolism. The CT pulmonary angio today is the gold standard for ruling out pulmonary embolism, and if your clinical suspicion is very high, I think one should depend on CT pulmonary angiogram after the D-dimer test and an echocardiography to show you right atrial, right ventricular dilatation. One could look for an aortic dissection. If the clinical probability is low, then probably you have to consider alternate diagnosis. But if your clinical probability is high, one needs to look at CT aortogram or an MRI, an angiogram of the aorta. One could even do a transthoracic echo or a transesophageal echo. The gold standard is the CT aortogram or an MRI angiography of the aorta. So a patient with chest pain, acute coronary syndrome, pulmonary embolism, aortic dissection, three major can't miss causes of chest pain, because if you miss this diagnosis, send the patient home, he will be brought back dead. So one has to be very careful in ruling out. Here, but as taken from a textbook, if you have a gastrointestinal cause for the chest pain, one needs to do an esophageal endoscopy, look for erosive gastritis, or look for a non-erosive esophagitis, or look for an esophageal manometry and look for any esophageal motility disorder, or look for a esophageal hypersensitivity by doing a 24 hours pH monitoring of the esophagus. So one can do a series of tests for the gastrointestinal workup, in addition to an ultrasound abdomen, to know what could be the cause, gastrointestinal cause for the chest pain. It could be a referred pain from the abdomen. For the general physician, it's very important to understand that the common etiology of gastrointestinal, musculoskeletal, respiratory, and psychosomatic are more common than a cardiac cause. There is a score which has been given called the Marburg heart score, which is used for the differentiating in general practice setting what could be the etiology. And the Marburg heart score criteria is 1 point each. If you are more than 55 years or woman more than 65, in Indian setting probably I would say is 45 and 55. Known vascular disease, previous TIA, previous coronary artery disease, previous history of vascular pathology. Symptoms are induced by exercise. Pain cannot be induced by palpation, that is, there is no local tenderness. And the patient suspects, very important point, the patient's opinion is taken here. The patient suspects that heart disease is the cause, then probably one should think that this could be a coronary etiology. So if you have more than 2 points, one could say probably it's a coronary artery disease as the etiology. If it's less than 2 points, one could say it's a non-cardiac origin of the chest pain. And distinguishing between various life-threatening causes of chest pain based on the presentation and diagnosis: pneumothorax, pericarditis, pulmonary embolism, aortic dissection. We'll talk about this in the subsequent slides. A host of causes for the chest pain. Non-coronary causes for chest pain: aortic dissection, myocarditis, mitral valve prolapse, pericarditis, stress cardiomyopathy, that is Takotsubo cardiomyopathy. Chest wall causes: cervical disc causes, costochondritis, fibrositis, herpes zoster, neuropathic pain, rib fracture, sternoclavicular arthritis. Pulmonary causes, a lot of pulmonary causes are very common. Panic disorder, anxiety disorder, hyperventilation can all produce a typical sharp chest pain. A lot of gastrointestinal causes are there, the list there. We are not familiar with that. I don't want to go into the list, but mind you, gallbladder disease, esophageal disease, and pancreatic disease are the common causes for the gastrointestinal causes. So what is important is that we do not focus only towards the acute coronary syndrome. We look at other causes of chest pain. Approximately 60% of the chest pain diagnoses are not organic in origin, that is not cardiac, not gastrointestinal, not pulmonary, probably musculoskeletal, or probably psychosomatic. Let's look at a few case challenges what I had in my experience for the last 6 or 7 years. This was a 32-year-old male who presented 1 week after the chest pain. He had visited 3 physicians, 2 cardiology hospitals, and came with this history. He had a sudden onset of severe chest pain anteriorly while having a bath, profusely sweating. There was an intense weakness, drained of energy, and he laid down on the floor of the bathroom for 15 minutes. He couldn't get up. After 15 minutes, he crawled out of the bathroom naked. Now this is what he said: "I didn't have clothes, sir. I didn't have the energy to wear on the clothes. I just crawled out of the bathroom. Again, I couldn't have any strength. I lied down on the floor for 30 minutes. He could then stand and then called his friend, who brought him to the hospital. Outside in the clinic, he had an ECG, an echo, a chest X-ray, a complete blood picture, random blood sugar, and troponin. All were negative. He visited 3 hospitals and repeated all the above tests over a span of 1 week, and all were negative. Somebody prescribed him NSAID, somebody prescribed him alprazolam, somebody prescribed him proton pump inhibitors. He came for opinion to Yashoda. His vitals and general examination were almost normal. He just said 1 week back I had pain, so these are the investigations, and a lot of investigations were done for him, including vitamin D and vitamin B12 and folate levels. He was evaluated by the registrar in the department. He repeated again an ECG and 1 more echo. The blood pressure at this time was 160 by 100. He came to me in the afternoon at 3 o'clock, and when I took the history, I said, this needs one specific test: CT aortogram. Now that showed an intramural hematoma in the ascending aorta. There was a break in the intima of the aorta. There was an outpoaching in the ascending aorta of the CT scan. With a matter of 10 minutes behind the CT scan, he was admitted in ICU. There's a lot of disbelief, denial on the part of the patient and the attenders. All the other doctors said normal, and here you're saying something major is going wrong and you admitted in ICU. A CT surgical opinion was sought the same day. He was staying alone at Hyderabad and he wanted his family to be informed. They were in North India, in Jabalpur or somewhere. He was getting married in 2 weeks and we told him, look, this is not the time to get married. But he insisted, went to Lama. And a month later, he was readmitted with diarrhea. 2 days of diarrhea. He got married. There were a lot of parties and partying and dinners for him. And with diarrhea, he was admitted. He reached the 5th floor in the ward. He was supposed to be admitted in the ward by the wheelchair. He lay down on the bed and had a cardiac arrest. He was shifted to ICU. We did a CPR. We did an urgent echo there, and we found that he had a cardiac tamponade. He died within half an hour after he reached the hospital. So this was a 32-year-old male who presented with a very typical symptoms of acute aortic syndrome. When we took his history, it was very classical. He had a sudden severe pain, excruciating pain, like a bolt of lightning. He almost said he was going to die. And all the reports were normal. But there was something abnormal in this. ECG normal, echo normal, chest X-ray normal, blood test normal, everything was normal. Mind you, one investigation which was not done was a D-dimer test. Think of vascular causes, acute aortic syndromes, dissection of aorta, intramural hematoma of the aortic aneurysm, and aortic aneurysm are the common causes for acute chest pain. Life-threatening conditions, one needs to pick up these conditions. This is the classical dissection of aorta wherein there are 2 layers of a true lumen and a false lumen with an intimal flap. This is a intramural hematoma. There is no break in the continuity of the intima, and that is the intramural hematoma. Here there is an ulcer-like outpoaching in the aorta with the intimal break. This is the classical again intramural hematoma. This is the break in the adventitia also. This is a class 4 with the hematoma forming outside the aorta. And this is over the catheterization techniques. When we put the tubes and wires, we can produce a dissection there. This gentleman had between class 2 and 3 intramural hematoma, classical pain. He denied treatment, went home, came back with a cardiac tamponade, which is quite common. But 20% of the patients who are in this stage land up with a cardiac tamponade and die instantaneously. The best imaging modality is a CT scan or an open and giving you the flap in the aorta. And one could look at the transesophageal echo also and tell that there's a flap in the aorta there, the descending thoracic aorta and then the arch of the aorta. A cardiac imaging is absolute must, but you should know which patient to order this test. The history is very, very important. There was a sudden thing and then there was a clap. A severe pain in the anterior chest. When you have the pain in the anterior chest, the etiology is often in the ascending aorta dissection. When the pain is in the back interscapular region, the dissection is mainly in the descending thoracic aorta. So depending on the site of the pain, you can decide whether it's a ascending aortic dissection or a descending thoracic aorta dissection. So although the patient had equal blood pressure in both the arms, does not rule out aortic dissection. So it's very important if you're suspecting aortic dissection, look at all the 4 pulses, neck pulses, and see if there is a flap occluding one of the limb vessels. Going by this, we have the Stanford and the DeBakey classification, where in the DeBakey classification, the ascending aorta and the entire descending aorta is involved. DeBakey class 2, it's only the ascending aorta. DeBakey class 3, it is only the descending thoracic aorta. Stanford A is proximal dissection and Stanford B is distal dissection. So depending on the etiology of the dissection, one could say, especially if you have a Stanford A where you have the ascending aortic involvement, surgery is the modality of treatment without delaying it further. Do not delay the surgery. One can start beta blockers, titrate the heart rate, labetalol, blood pressure control is very, very important. But if it is Stanford B, where it's a distal dissection, a descending thoracic aorta, one could just treat with blood pressure lowering drugs, analgesia, and consider surgery if there is an end organ damage. We do what is called an elephant trunk surgery, where we replace the arch vessels onto a prosthetic graft. We cut the subclavian, the carotids and subclavian innominate arteries and put it on a graft, and then put a stent graft from below to reinforce the graft there. This is a hybrid technique where the surgeons, cardiothoracic surgeons and the cardiologists do a hybrid technique and repair the dissection of aorta there. The second case which I missed was one Mr. Meher Baba. He was a Ranji Trophy player. He was my patient for almost 10 years. And he came in the left parasternal region, and it was a constant pain, not worsening with activity. He was a cricket player. He used to do some training matches and all that in the Lal Bahadur Stadium. There were no risk factors. His ECG, echo and chest X-ray were reported normal. Blood chemistry was negative. TMT was negative, but still he said, let's do an angiogram. And the angiogram turned out to be normal. He was discharged with reassurance on statin, aspirins and NSAIDs, and said, this is probably a musculoskeletal pain, a costochondral junctional pain, nothing more. He came back 2 weeks later. His ECG and chest X-ray were repeated. It was normal. He came back at 4 weeks and said, Doc, this pain is not going, it's getting worse. I want you to test me once again. We repeated the ECG and X-ray. It was reported normal by the radiologist. But when we looked at the X-ray lobby very carefully, there was a small coin lesion in the left hilar region. And that same next hour, we did a CT guided chest biopsy, and he had a small cell lung malignancy. So a constant dull pain for more than 3 to 4 months, focal pain, should have raised the suspicion that it could not be of coronary etiology. Probably it's a musculoskeletal pain or something beyond. And this was a pain from the malignancy infiltrating the nerve and producing a intercostal pain there. He had a chemo, he had a surgery, died 6 months later. So a constant pain for days and weeks is unlikely to be of cardiac origin. Local tenderness, relief with NSAIDs suggest an inflammatory etiology, costochondritis or teeth syndrome or musculoskeletal pains due to undue physical activity. Like for example, he's a cricketer who was to do the bowling and batting, so we thought probably it's because of that. Or a new physical exertion. Somebody is going for joining a gym and has done some undue exercise, lifting weights or doing some severe exercise, could develop a local cause, musculoskeletal cause for the chest pain. One has to follow each investigation carefully. Critically look at the chest X-ray if you're not able to explain, or any other investigation. Discuss the imaging reports and lab reports personally if in doubt. 3 chest X-rays done in a span of 1 month. All that showed the coin lesions, but none of them was reported in the X-ray report. So one missed, but fine. He was already in a stage of infiltration of the chest wall, so his pain was, he was almost stage 3 malignancy by the time. A 60-year-old male in case 3 with chest pain radiating from the back to the front of the chest. Severe pain of 2 days duration. ECG showed a left bundle branch block. We thought, okay, this is the new onset LBBB. This guy is having an MI. Take him to the cath lab, did an angiogram. He had a minimal mild CAD. He was discharged on statin, aspirin, Alprax and PPI, saying it would reduce. He came back 3 days later with more severe pain, unable to stand or sit, radiating from back to front. A resident in cardiology attended to the patient in the emergency department. Any cases? Okay. The general examination was the patient has to be thorough. We rarely undress a patient to look at the skin and start from the skin, look for the herpetic skin vesicles or erythema. Herpetic neuralgia can precede a skin eruption by a few days to a week. The patient was undressed in the cath lab for draping before angiogram, and there were no skin lesions for this individual. But the resident found these skin lesions 1 week later when he came back for a follow-up. Grouped vesicles with underlying erythema in a dermatomal distribution responsible for the we could predict because there were no skin lesions. Herpetic neuralgia, a skin cause for a typical chest pain. This was an interesting case. One of my relatives, morbidly obese lady, 108 kilograms, diabetic, hypertensive, obstructive sleep apnea, presented with recent onset breathlessness, class 3 and a chest tightness. ECG showed some T-wave inversion, L1, AVL, V5, V6. Echo was normal. Within 2 hours, we took her to the cath lab, did an angiogram, reported normal angiogram. 2 hours later, the investigations came. Her hemoglobin was 5 grams and she had bilateral pleural effusion. She was in congestive heart failure because of the severe anemia. A pleural tap suggested a Cox etiology for the effusion. So one has to remember, it's just not coronary all the time. One has to think of the pleural etiology. One has to think of the pleural effusion, an inflammatory pathology, a pneumonia or a pneumothorax as the cause for the chest pain. Pulmonary embolism is another one of the causes which could be disastrous. The location of the pain could be very classical, retrosternal, could be pleuritic chest pain, coexisting with dyspnea, tachypnea, tachycardia, which can all come with acute coronary syndrome. Of course, some could have crepitations and hemoptysis. If you have this, the diagnosis ABG, ECG, chest X-ray, none of them can give a diagnosis or a clue. But what can give a clue is sometimes an ECG which is showing a RV strain pattern in V1 to V3 or V4, and an echocardiogram showing a grossly dilated RAR, right atrium, right ventricular grossly dilated there, with a hypokinetic right ventricular wall, and the pressure, PA pressure is quite high. The pulmonary embolism is one of the etiologies. Chest X-ray was normal. The blood gases was normal. ECG was almost normal except for some non-specific changes. The CT pulmonary angiogram showed the pulmonary embolism, saddle embolism sitting across pulmonary embolism. She was thrombolized with tenective place and she did well. The patient we had, a 46-year-old male present with lower sternal pain of 6 months duration. The pain is worsening after food intake and he preferred to be in a fasting state. He said he lost weight because he was not eating. It was not aggravated by exertion. And a postprandial, we thought probably it's a postprandial angina, a class 3 angina. He was evaluated by the gastroenterologist and the cardiac specialist. Again, ECG, echo, TMT was normal. We started on PPI, statins, advised endoscopy. He was scared of endoscopy, did not go for it. No relief in multiple trials of omeprazole, pantoprazole, esomeprazole, so many drugs and combinations. On reviewing the history, he said dysphagia was his main complaint rather than a lower sternal pain. The barium swallow revealed achalasia cardia. That's the typical parrot beak appearance, the lower end of esophagus, and that's the stomach there. The parrot beak appearance of the achalasia cardia. One again, an atypical cause for a chest pain, which is usually ignored or not seen. But today, with the endoscopy being such rampant there, one would have rarely missed this, except that he did not go for an endoscopy because he was scared of the endoscopy procedure itself. Achalasia cardia is one of the causes, wherein we can do a various sizes there, or you can go for a myotomy. If there's a failure, one could do a repeat myotomy or a pneumatic dilatation. With a very high surgical risk, one can give a botulinum toxin. And if there's a failure, one could try nitrates and calcium channel blockers to relieve the esophageal spasm. One common cause, rare cause, but we had this experience there. Sixth case, a 65-year-old male present with sharp right upper quadrant abdominal pain, very sharp along the costal margin, with profuse sweating and nausea, no vomitings, no fever. Seen by the gastro team, found to have stones in the gallbladder. LFT was normal, blood chemistry was normal, including serum melis, but normal there. He was referred for a cardiac fitness for gallbladder surgery. When we reviewed the history, he said the pain was very sharp for more than 20 minutes with drenching sweats. Now, one doesn't get a drenching sweat with a gallbladder stone. It was quite unusual. We said, look, We would like to rule out a cardiac cause because you had a sweating. And his initial investigations were normal. The suspicion was strong, so we took him for an angiogram straight away. He had a 99% critical LED lesion. ECG normal, echo normal, X-ray, everything was normal, enzymes were normal. The gallstones was a red herring. Just because they found the gallstone, it doesn't explain the chest pain. It doesn't explain the right upper quadrant pain with profuse sweating. It's an atypical feature with gallstone there. And there was no fever, nothing else was there. Case 7. 38-year-old male present with epigastric pain of 4 hours duration. I'm going to stop in another 3 minutes. With profuse sweating, vomitings and mild breathlessness. 4 hours duration of chest pain. Was a smoker, consumed spicy food at a dinner with alcohol, the diabetic, normotensive, family history of CAD. All pointing towards epigastric pain and inferior etiology, MI or something like that. ECG revealed some STT changes, concave upwards in ST segment in the inferior lateral leads with tall T waves. The vitals were stable, there was no pericardial rub. A provisional diagnosis of infralateral MI was made because of the ST segment changes, the tall T waves. In view of the typical angina and ECG changes, he was advised PTCA or thrombolysis, primary PTCA or thrombolysis. He was out of the window period of 4 hours. So the family preferred thrombolysis because they could not afford a primary PTCA. So we thrombolized him with STK. And what happened post-thrombolysis? He continued to have the pain and received all the adjunctive therapy, aspirin, clopidogrel, statin, nitrates, heparin, beta blockers, pantoprazole also. Serial ECGs, however, the next 3 days did not show any progression in the ST segment changes. It remained as at admission and the T waves remained tall. Echo was normal, there was no definite RWMA. We suggested an angio in view of the failed thrombolysis because the pain persisted and the ST segment changes persisted. They refused. However, the next 3 days the ECG remained as at admission. Pain decreased and became more comfortable, but serial cardiac enzymes were not rising. We had a typical chest pain, we had an ECG changes, we thrombolized him, but the enzymes are not rising. What happened? Somehow we convinced the attenders for the angio, and angio showed normal coronaries. And what was the diagnosis? We reviewed the history and sent a serum amylase and lipase, and it was sky high. The diagnosis was acute pancreatitis, and we had thrombolized him just based on the ECG. The ECG was actually showing an early repolarization because of the concave upwards STT site changes, and it was an acute pancreatitis which we had thrombolized thinking it is an acute MI. One of the, again, very disastrous consequences. If the pancreatitis had turned hemorrhagic transformation, he would have been in more trouble. I would have been in more trouble. So, pericarditis, pancreatitis, acute cholecystitis, gallbladder etiology, pneumonia, pneumothorax, all of them can result in an acute chest pain syndrome. And one has to differentiate and rule out these etiologies of pericarditis or aortic dissection or pulmonary embolism before you say you have a patient who is safe to go home from the, just skipping a few slides there. A lot of non-cardiac chest wall cause of chest pain like cervical spondylosis, costochondritis, fibromyalgia, neuropathic pain, rib fracture, sternoclavicular arthritis. Panic disorder of psychiatric etiology could be some of the causes for a chest pain. Patient with panic disorder, when he does hyperventilation, develops muscular spasm and severe chest pain. He's not telling you a lie, he's going through the chest pain, but we know it is a non-cardiac chest pain. A lot of causes for costochondritis, which can be relieved with non-steroidal anti-inflammatory agents, sometimes a local anesthetic, and is giving the intercostal blockage there to relieve the chest pain. And one of the most common causes, NSAIDs, local heat, local infiltration, and gentle some stretching exercises sometimes helps. For the gastrointestinal causes, we have already gone through endoscopy, pH monitoring, esophageal manometry for ruling out echinocardia, acid suppression therapy, empirical therapy can be tried, and a lot of other causes can be done to pick up. One important message which we'd like to give through this talk here is, Life-threatening cause of chest pain, triage the patient depending on the hemodynamics, the ECG changes and echo, whether he is likely candidate for a death immediately, and one can rule out by doing an instantaneous investigation. It just takes about 3 to 5 minutes to do this investigation, a CT coronary angiogram, to pick out if there is an abnormality, and if it is abnormal, probably one could be admitted. So today, the guidelines are saying, as a first-line investigation for somebody who comes to the emergency department with chest pain, it's not treadmill, it's not stress thallium, it's suggesting a CT coronary angiogram as a first-line investigation. If you are suspecting an aortic dissection or a pulmonary embolism, one is suggested to do a triple rule out. A triple rule out is a condition where you rule out dissection of aorta, pulmonary embolism, as well as a coronary pathology for a chest pain. So clinical stability is very important. Impending circulatory or respiratory collapse. If he is in this category, you need to be very, very aggressive in his management. What is the immediate life risk? Then you can triage the patient into non-urgent or urgent, benign, non-cardiac, cardiac, coronary, non-coronary. History is very, very important. The time and tempo of onset, like the dissection of aorta patient had a sudden onset of clap like thunder like pain. That's very instant. Coronary pain builds up gradually over 20 to 30 minutes. Angina tends to manifest the same way in a given patient. Physical examination is very, very important. Serial ECGs, echocardiography, chest X-ray, biomarkers, serial troponins, D-dimer, and a triple rule out CT angiogram is the way to go today. One important point, the left circumflex artery is poorly represented on a 12-lead ECG. So if you have a coronary occlusion, left circumflex occlusion, your ECG is going to be normal 5 times, 6 times. But if the pain is classical, your ECG is non-diagnostic, your echo is non-diagnostic, one can directly take him for an angiogram or a CT coronary angiogram. So thank you for your patient hearing. If there are any questions, I'd like to answer them. Some major pitfalls: wrong diagnosis, overdiagnosis. Where we have erred, we don't want you to make the same mistakes. So with my experience, what I felt for the chest pain of non-cardiac origin, non-ischemic origin was what I wanted to highlight and bring to your awareness so that we don't commit the same mistakes again. Any questions?
So that acute pancreatitis case, was a troponin done for it?
No, this was in 2002. We didn't have a troponin available with us. We used to depend only on CPK, CKMB for our diagnosis.
It was not elevated at that?
No. So for a patient who has a classical ST elevation, a classical T wave elevation, a T wave becoming very tall, epigastric pain, nausea, vomiting, 4 hours duration. The diagnosis was MI with ECG and echo and the ECG and the chest pain. That was enough for us to diagnose MI. So the cardiac enzymes were not set on the first day. Today also, we don't do cardiac enzymes for every patient with MI. We know it's an MI. There's no point in doing a cardiac enzymes. 24 hours after the admission, the resident on duty, registrar on duty, said, sir, the ECG changes are not improving, are not worsening. Usually you have a T wave becoming tall, the next day T wave becomes inverted, next day ST segment comes down. So there's a serial progression of the ECG when you have an MI. Here the ECG was frozen. First ECG is the same as the fifth ECG. So the registrar on duty said, I want to send cardiac enzymes. We said, why do you want to waste the money? He's already proven MI, we've already thrombolized him. He sent it without informing. It came normal. Second day he sent it, it came normal. Third day he sent another cardiac enzyme, CPK came normal. We said, what's happening? It's an MI, we diagnosed an MI, ECG is frozen, enzymes are normal, we missed something. And that was acute pancreatitis.
Chest X-ray. So all normal. Only painkillers were given, and he did not have. This was not on the left side; it was on the right side. he was not relieved. And later on, after 2 to 3 months, he had some small abdominal problem, for which he went to surgeon, general surgeon, ultrasound scan. So the gentleman went to the same radiologist where the first chest X-ray was done. So while doing the ultrasound, that particular radiologist put probe on the thoracic area, and he found there was some difference and there was some light lesion. So yeah, light lesion, light. He asked for the previous X-ray, and for a free of charge, he took a second chest X-ray for his own curiosity, and it showed clear light lesion in the ring, and it was diagnosed after a pretty long time as a rare disorder of LCH. Langerhans osteoarthritis. So that's why I just wanted to share. And I really appreciate your effort in putting the wonderful cases, particularly these last 8 cases. Thank you very much, Dr. Sashikanth.
Thank you, sir. Not seen clinically thoroughly. If your investigations are not explaining the cause for the chest pain, go back to all the investigations, repeat your echo, repeat your ECG. Be satisfied that you have done a thorough job with your investigation. A minor wall motion abnormality, a mitral prolapse, dilatation of the aortic root, a bicuspid aortic valve. These are the various causes which you can miss in the first line. When it's done in a diagnostic center elsewhere, where the clinician is not interested in doing the clinical correlation with the symptom and the investigation. You tend to miss, for example, a chest X-ray. Gentleman had a fine lesion in the chest for 3 months. 3 X-rays done, reported normal, and if the report is normal, I would not look at the X-ray. We didn't focus in mind. The 3rd X-ray, constant nagging pain. 3rd X-ray was reported normal, but when we went back to the radiologist and said, "No, sir, यहाँ कुछ दिख रहा है." We do a CT chest. It was already late because chest wall infiltration is stage 3 diagnosis. Any other questions?
Thank you, Dr. Sashikanth. I would love to listen to your talk. Really, the chest pain, there are so many pitfalls. I recently had a case, about 55 years lady, non-diabetic and non-hypertension. Her main complaint was epigastric burning pain. She was very anxious lady, lot of functional overlay. 2 or 3 times she was admitted. Main complaint was burning pain, not getting relief. We had tried all the antacids and the PAs and all those things. Then she started having a vague chest pain. ECGs, repeatedly ECGs normal, chest X-ray normal. Then I got fed up and I referred to a cardiologist. Finally, I thought, let us take cardiologist. Then, there also the other ECG is normal, echo is normal. Somehow, our cardiologist conducted angina. They found left main and LA lesions. Then they came back to me. The cardiologist spoke to me. So she needs bypass surgery, CABG. Then I referred the patient to Dr. Asad, our teacher. Then he has seen the cardiologist film. He was convinced that definitely the 2 lesions are there. Then he has done TMT. TMT was normal. Then he suggested conservative management. If later on the patient becomes symptomatic, definitely she needs bypass surgery. My importance is that always misleading. Whenever there is doubt, definitely I take cardiologist. Thank you, sir.
An example of what we were looking at. Just because there is a coronary lesion, a 50%, 60% lesion, it doesn't explain the chest pain. It doesn't explain the chest pain. Somebody comes with a persistent left upper limb pain. After all the investigations we find, we did an angiogram and we found a 60% lesion in the LAD. it doesn't explain the left abdominal pain. It has to be 90%, 95%. So just because there is a coronary lesion, it doesn't mean that that symptom. If there is a 90% pain, 90% lesion in the baby, and the pain is quite atypical, we still feel the pain is not because of this LED lesion. We tell the patient, look, you have a lesion, it is critical. You need to go for an angioplasty or surgery, but your pain is not going to be resolved. Your pain in the left upper limb is going to remain. Because tomorrow after the procedure, they will come and ask you, दर्द कम नहीं हुआ? इतना बड़ा ऑपरेशन करे, 2 लाख हो गया, pain कम नहीं हुआ? So we tell them beforehand, this pain is not cardiac lesion, but coincidentally we found a critical lesion. You have to go for a revascularization. So just because there is a lesion doesn't mean there is that pain is responsible is coming from this lesion.
Cerebral bleed was treated as a non-QMF. Cerebral bleed.
Cerebral bleed.
Cerebral bleed was treated as non-QMF.
Yes.
I came up with a situation as a resident exams. A call came from casualty saying the patient with chest pain came there. The atypical chest pain. When the patient complained of nausea, vomiting and wrenching sensation of the throat, thorax region. When we took ECG, the clearly TV changes were there. We got to putting ECG, taking the monthly and TV changes, they repaired it. Next day morning situation worsened. When a neurology was taken, CT scan of them, bleed was
Subarachnoid with a lot of ECG changes can mimic an acute MI, can mimic a non-QMI, can mimic a non-STEMI. Subarachnoid hemorrhage or a intercerebral hemorrhage. So ECG can be mimicked with this integrated anatomy. One needs to be very, very careful when you're handling heparin, aspirin and clopidogrel for these patients. So very good example of a non-cardiac chest pain, atypical chest pain with ECG change. One needs to take the history very carefully. Thank you. That's a good point.
Bilateral pleural effusion. Was the chest X-ray taken prior, sir, or was it missed out, sir?
So, this lady happened to be my relative. She came to my OPD, took an out-of-turn appointment, walked in and said, I have got a severe breathlessness last 3 days and I'm unable to walk, unable to have a bath, and I'm really tight in the chest, very tight. She's 108 kilograms. ECG was showing abnormal, echo was normal. We said, look, she's diabetic, hypertensive, obesity, obstructive sleep apnea. What else can be class 3 breathlessness with a silent lung? The chest X-ray was not done. She straight went to the cath lab suite, had an angiogram done. 2 hours after the angiogram, we got the hemoglobin as 5 grams because hemoglobin comes later, 2 hours later. It took just 2 hours to finish all the tests. 5 grams hemoglobin, and the breathlessness was because of the 5 grams hemoglobin, and she had a bilateral pleural effusion. This was next day. We did auscultate the chest, but with that obesity, the breath sounds are hardly heard. You cannot even make out whether the breath air is entering her lungs or not. So we heard the lung sounds, normal or reduced, but with that obesity, you cannot make it out. So we just took her to the cath lab. Next day, the hemoglobin and chest X-ray, those reports came, and she was treated for pulmonary etiology. So it's possible that you miss out if you don't do a detailed examination, a careful examination. This can happen.
It was just a small clarification.
I hope I have done justice to my topic. I thank Angela, thank you, Doctor, for giving me this opportunity to be in front of you today and giving you this small talk. Thank you.